Hi, we're starting the medically complex disease management training, and this will be hour one. We're going to start with the, I think it's called Participant Manual 1, and just open your manual to the first page. Is called Program Goals. We're not going to go over each point. I'm just going to try to hit the highlights. I'll try to keep you up with the title of the slide, but if I forget, just try to keep up. The first slide called the Program Goals. We're going to identify and describe specific medically complex disease processes, perform effective assessments, and by that we're talking about we need to use standardized assessments. All therapists need to use the same language. What is good endurance? What is fair activity tolerance? What does tolerated well mean? Does that mean the patient didn't die from your exercises, or does that mean that your patient had a grand old time and sent you a thank you card? The measures have to mean the same to everyone who reads your note. We need to develop effective treatment plans. We need to get down to the impairment that is causing the functional problem. The functional problem might be far too advanced for the medically complex patient. The fact that the patient requires maximum assistance for supine to sit or has 25% PO intake needs to be broken down to the impairments for some of these patients. It's too far-reaching to set a short-term goal that the patient will require mod assist for supine to sit in 4 weeks, or to increase their PO intake to 75% in 4 weeks, for a seriously involved patient. Many steps need to be achieved before we can even talk about the usual kinds of functional goals that we write. For a medically complex patient, we may need to write as a short-term goal, the patient will roll to the left side and move lower legs over the left side of the bed in 4 weeks, or the patient will have increased tongue strength such that able to lick soft serve ice cream cone or lick 20 stamps in such and such amount of time. I'm not a speech therapist, so pardon me if I'm using bad examples, but you get the idea. For example, maybe they can't roll and come to sitting in the bed because they lack torso rotation. They can't rotate their trunk. Now, is that due to lack of strength or to tightness in their torso muscles? Is it due to back pain? Is it due to upper extremity weakness, hip flexor tightness, motor planning deficits, inability to isolate movements due to Parkinson's? So what all do we need to work on so that they can achieve that part of the puzzle to be able to come to sitting? In the example about not being able to increase their oral intake, break it down to their impairments. Maybe we need to set a goal for very simple tongue and lip or cheek movements. Maybe they've got poor oral hygiene that's causing biofilm and it's leading to inability to taste their foods. Need to review their medications, the possible side effects of their medications affecting their appetite or taste. And to document, and utilize a variety of therapeutic strategies to meet those goals. Back on the slide. Document those medically complex conditions. And then another program goal is to identify emergency or unusual patient responses which need to be monitored and reported. And we'll get into all those areas later. Medically complex, I'm sorry, I almost skipped a real important one. This triangle here beside me, that's kind of the flag, the theme of this whole training. It's similar in concept to Maslow's hierarchy of needs. You remember that in high school or college, where the pyramid has their basic needs at the bottom, moving toward self-actualization at the top. You have to have basic needs met at the bottom before you can move to the goals at the top. And when we think about therapy, when you got into therapy, think about what does the therapist do? And for PT and OT, it's, oh, we work on ambulation, dressing, buttoning your shirt, those kind of things, walking. For a speech therapist, we work on communication and swallowing. But before you can work on those things, there are more basic needs. And I know you can't see mine, but if you turn in your book to you've got the same diagram in your book. If they're not able to breathe, if they're not focused, if they're not cognitively aroused, if they're half out of it, if they feel unsafe, if they are expending so much energy just trying to breathe and be, they can't even think about the things I was talking about earlier. And we're trying to drag them down the hall or get them to work on what came first, setting up the razor or shaving their face. And we're trying to get them to concentrate on those things. And they're trying to breathe, or they're trying to figure out where to put their foot. We all have had those patients where they're raising their leg up in space and setting it on the table, and you're saying, put your foot on the floor, and they're wandering around in space. They don't even know where they are. We may need to be working on sensory STEM things, putting them in a weighted blanket or a vest, or those kind of things, and we're working way up the pyramid. So we may need for these medically complex patients to bring our functional goals way down, which for us we're thinking, well, that's not functional. Well, yeah, it is functional. We just need to bring it to a lower level so that we can have a base to build on, so that we can move higher up. It's the same, and why we have trouble seeing it for a big person, a physically big person, is kind of what's the word I'm trying to think of? A change in our thinking. We don't have trouble thinking of this for little people, for infants moving through infancy to toddler to preschool, that we have to teach them small things first before they're able to understand bigger things, or they have to physically overcome, learn small things to be able to overcome or learn greater things. The same is for somebody who's been very ill or who has cognitive deficits. We have to lay the base first. So there's my soapbox on that. Okay, medically complex definition slide. The point on here is we don't want to stop at patient refused. We want to dig deeper. We want to drill down to the reason that they are refusing. We don't mean badger the patient, but investigate why they're refusing. And that's not to say we don't have some stinkers. We do. We have some people that are they're either stinkers or they're just tired. They just have made the decision that they don't want to do it anymore. They don't want to participate. They don't want to be active anymore. They just want to lay in their bed and wait for nature to take its course and to pass away or whatever. But we need to make sure that there isn't something else going on, physically, psychologically. They may have poor coping strategies, poor life planning skills. What is preventing the patient from participating? What will light his fire to get him to participate and make life happen? Chase down the reason he's not getting his pain medications, getting his shower, his lunch. Why, is it that he doesn't want to do those stupid cycling exercises, or whatever he thinks is stupid or is not going to help him? Does he not understand why we're doing such and such exercise? Figure out a different way to achieve the functional goal. Do the exercises from the shower or in the shower, or while he's dressing, or doesn't want to do the arm exercises. Okay, he can propel down the hallway in his wheelchair. Let's figure out a different way to achieve the same movements, the same aerobic goal, the same shoulder movements. The idea that a patient, if he refuses 3 times, then we discharge him, that's an old therapy myth. Now we're talking about Part B patients, because Part A we do have to, they do have to participate. But if the documentation reflects that you are actively working on getting the problem resolved, we can continue to keep them on caseload. But I'd say that specifically saying if you're working on dealing with or getting referral for their grief, for their resolving their continuing pain issue, or their orthopedic issue, they need a brace or a splint or whatever is causing them to not be able to participate, and you document that you are making active, taking action on getting this problem solved, you can keep them on caseload. If refusals is an individual or a facility-wide problem, I created a form because at one of our facilities we were having this as a problem. Where did I put it? There it is. And it's very easy to use, and you don't have to use it. You don't have to use it. It's just a form I came up with, and you can use it in actuality or in concept. It's right here. Well, let's see if I can get it on here. And some of the others can show it to you. It's just called a record of therapy missed visits, and it is, you date it. You can, it's per patient, so you put the patient's name on it, the date, the time, and the therapist's signature, the reason for their missed visits, and it's all a check form. So was it dialysis, a doctor's visit, they refused, they were ill, or something else? And then what was the action that was taken? You counseled the patient. You counseled them that their personal goals require daily therapy participation. You counseled the patient that insurance coverage is dependent on daily participation. They requested pain meds. You offered an alternate time on the same day, different location, different therapist. They were counseled by a team member, and you write in their name. They were counseled by the RPC. You requested a referral to a psych or some other specialist or something else. And then in the next column, they agreed to participate as a result of the action. If yes, great. If no, circle no. And if no, who was notified? The unit nurse, write in their name. The director of nursing, social services, the doctor. How were they notified? By phone, fax, some message board? The responsible party, who? And by in person, phone, voicemail, or some other way. And then this is just kept on them, be it once, they refused a given day or 5 times in a day, and it gets chased down. And some examples of how this has been successful in the past. We had some patients who said, I'm here to rest. I'm not doing therapy. I'm here to rest before I go home. And we kept having a number of people say that. And so we went to the admissions person and said, are you telling, nicely, we didn't challenge her, but said, are you telling people that they are coming here for therapy and that their Medicare A coverage is dependent on them participating? Yeah, I've been telling them that. And after we, did this form on a few people, and a number of people said, I'm here to rest, it seemed like magically we quit getting that excuse. So we were able to chase down and document where, what was happening, or that whenever we went to, this person was requested a pain medication, we went at, they requested at 11, and then we went back at 12:30, and we went back at 2:30, and kept that we notified nurse Susie at each one of these times, and never got their pain medication. All of a sudden, that Susie got a little more on it on getting her pain medication. Or we identified that the family kept saying, "Well, Mom said she'll participate. All you have to go and do is go in and ask her." And then we're able to show um, the family member, "Well, we went in and asked her all these times, like you said, and she refused. And here were her different reasons. The show was on. She was tired. She wanted to take a nap. It was time for lunch. All these different excuses, and it became evident that there was an issue that she, and all these issues can be worked out. And some people have shown this too, said, "Oh my gosh, that'll take so much time." It doesn't, because it becomes apparent very quickly what the problem is, and it chases the problem down very quickly instead of days and days of that she's refusing, and the building says, "Well, you're not trying hard enough," or "Are you sending somebody else in there, or are you going back at a different time?" It becomes evident very quickly what the problem is. Okay. Let me go to common issues associated with the medically complex patient slide. Shortness of breath, decreased participation, decreased intake, increase in edema in the extremities, decrease in cognitive status, confusion during or after an activity, decreased tolerance to pain, increased anxiety, decrease in ADLs not participating, refusal to participate in therapy or activities, low endurance, or the static hypotension. This is a list of common functional problems noted in our patients with complex diseases. And we will be addressing how to impact and measure these as we move forward in the presentation. Something to think about: are you treating a patient with a hip fracture, or are you treating a patient that has these issues who happened to break their hip? And I'm just using the hip fracture as an example. We need to remember that when we get this patient admitted with pneumonia or a hip fracture or a shoulder dislocation or whatever, is that their issue, or did they have all this going on? That's really their issue, and that the hip fracture or whatever just happened to be the precipitating issue that put them in the hospital. Another point that they scribbled some notes on in our training is document when a patient, what a patient tells you, that he didn't sleep, that he has pain. It may help us put the picture together about that patient at the time or in days to come. Also, facts about his confused state. Instead of just saying patient is confused, what about it? How are you determining that he's confused? Patient in therapy at 1:30 arguing with therapist about having to come to therapy in the middle of the night. Who knows how that'll come together? Maybe the next day you happen to note that you took him to the bathroom, urine with strong odor and dark, and the next day, that helps to support that he has a urinary tract infection. Of course, when you notice these things, you're going to report it to the nurse, but you're also going to document it. The age-related changes slide. There are a lot of changes that happen with aging. Fast twitch fibers atrophy more than slow twitch fibers. Bed rest and inactivity can cause 1% bone loss per week. There's a decreased ability to breathe deeply due to decreased elasticity of the lung tissue and decreased flexibility of the rib cage. Vision and vestibular system declines as we age. Respiratory patients often have nutritional issues related to decreased smell and taste. Aging is a normal part of life. However, the actual processes vary from person to person. The acute medical declines that many of our patients experience compound the impact of these changes. We lose 30 to 40% of our muscle mass over a lifetime. Fast twitch fibers atrophy more so than slow twitch fibers. Therefore, we're at a higher risk for perturbations on uneven surfaces. There's a decline in muscle strength as muscle mass declines. Strength decreases after age 60 and accelerates even more after age 80. Muscular endurance doesn't significantly change, The muscles of the legs tend to atrophy more than the upper extremities, and this is probably due to the continued use of arms with activities of daily living. There's decreased calcium absorption into the bone, which increases risk for fractures and contributes to general decline in mobility. It can be affected by caffeine, cigarette smoking, alcohol, gender, advanced age, weight loss, and physical inactivity. And I think of the little Caucasian women who weigh about 82 pounds, and she doesn't want to get up out of bed except to go smoke her cigarette and drink her 4 cups of coffee a day, and she's at high risk for breaking her hip. So, well, let's say she did break her hip, and she comes in, and it just builds the case for how important it is for her to get her weight-bearing exercise, her strengthening, because all of her other factors put her at such a high risk for fracturing again. And I'm sorry, my cats are making hissing noises. Uh, uh, it just emphasizes the importance of restoring the things we can restore to decrease her risk for fracture. In the cardiovascular system, the heart rate tends to remain normal, but the rhythm becomes irregular. Hypertension, postural hypotension, venous and arterial insufficiency. So the implications of that are that there's a decreased ability to respond appropriately to exercise. And there's an increased risk for falls, a risk for pressure ulcers. Respirations tend to increase due to the reduced ability to breathe deeply, because the lungs are less elastic. There's decreased flexibility of the rib cage, and there's presence of diseases like COPD, asthma, emphysema. So there's a decreased response, appropriate response to exercise, and a decline in mobility and function. There is gross atrophy of the brain tissue. So we're not talking about Alzheimer's. There's just atrophy of the brain with age, and decline in the vestibular system. There's decreased number and flexibility of the cilia in the inner ear, and that can lead to postural imbalances. In the sensory system, taste, the number of taste buds decreases with age, approximately by half by the age of 60, and the loss accelerates over the age of 70. The taste buds in the front of the tongue atrophy first, and those are responsible for sweet and salty. And therefore, the elderly person may crave sweet things. It takes more sweet taste to get that sensation or that sense of sweet. Let me get my papers straight here. There's also decreased saliva flow, and that causes an increase in gum disease and the loss of teeth. There increase in tongue fissures because of the decrease in saliva flow. This increase impacts appetite and can affect dysphagia issues. The sense of smell, there are loss of fibers in the olfactory bulb by as many as 75% by the age of 80 to 90. And diseases of the respiratory system can result in alterations in the nasal anatomy and the physiology. So the implications with that are the inability to recognize environmental dangers or body odors. So they may need to be, you may need to work, OTs and speech therapists may need to work on cognitive reasons for bathing instead of relying on sense of smell. Voice quality changes. Words per minute decrease because there's a decrease in breath support. Word labeling declines. Comprehension declines. Storytelling increases. Another, when I was at the training, there was a speech language pathologist who has built an entire niche of his caseload on volume, voice quality and voice volume, and how he screens for these patients. If he walks down the hall and says, "Hey, Miss Smith," "Hey, Mr. Jones," good morning, and if he cannot hear them easily respond to his call, then he picks them up, because he considers that a safety hazard. If they're in their room and fall or need some help and they're calling for a nurse and they can't be heard in the hall, he picks them up for either poor voice quality or volume. And I thought that was very, not shrewd, that's not the right word, appropriate, because if they have this little squeaky voice or very broken voice, they cannot communicate effectively, and it is a safety risk. So keep that in mind, speech paths. And we will be referring, and I'm saying PTs and OTs, be aware of that, because we're going to refer you patients if we notice that vocal quality or volume issues. Cognitive changes don't occur uniformly, so we can't assume that all people display some kind of cognitive decline. But changes severe enough to interfere with function are thought to be part of some form of dementia, not old age. Memory loss is the most common cognitive deficit. In the normal process of aging, the difficulty with recall of names, things, places, or activities is usually temporary and doesn't interfere with daily functioning. Older people can learn new skills, however, their learning styles may be different, like everyone. They often place more emphasis on self-direction, experience, and may require more time to process the information and react. Okay, now you've got a handout with all of those age-related changes. And what I like about this handout is under implications for therapy, those are good short phrases for that you can put in your progress notes under. Why do I keep forgetting the sections? Not skilled therapy, not like. It's on the far right. It's on the far right side. Functional implications. Functional implications. I'm sorry, I should have had this prepared. But you can use the implications for therapy as to impact. In the impact paragraph. You can use those. So, like, why do we need to keep seeing them for therapy? The implications for therapy, you can use that. Decline in mobility, decline in ability to perform ADLs, increased risk for falling, decline in functional tasks, decreased gait ability. I'm just picking out some. Decline in ability to communicate, decline in ability to follow directions, so that you might want to keep that handout handy. And then the patient identification focus area slide. According to an August 2012 Kaiser Health News Organization report, the national hospital readmission rate is 19%. I know you're getting tired. We're almost finished with this module. Rehospitalization rate is 19%. So people that leave the hospital and come back, almost 1 in 5 go back to the hospital with what they went into the hospital for, to get better. So it costs Medicare $17.5 billion in additional hospital bills. So what they should have been taken care of for. And so Medicare is saying, this has got to stop. So hospitals are going to be penalized for readmissions as in the way of decreased reimbursement for their services. And the report said that the penalties are going to fall heaviest on 7 states. And son of a gun, one of those states is Kentucky. And I looked it up online, and you can if you're nerdy enough and are interested, you can go to that Kaiser Health News report. It has a PDF of hospitals, and you can click on the hospitals. And I went through, and Stanford, in Lexington, Kentucky, Louisville, they're all of our major hospitals. Basically, if they take care of indigent patients, they are going to be penalized with lower reimbursement rates. Another point I wanted to make about that is we want to make sure that we are seeing the patients that need our services at the lower end. We may not be They may not be a candidate for restoring, but they may need services for a week, 3 times, 2 weeks. Let's say they're the comatose patient that keeps getting pneumonia, that keeps getting impactions, that their mouth is, they can't keep their mouth closed and they have terrible oral hygiene. And so maybe or that, you know, they moan, they're in pain, poor stimulation, that they're just in there in that room with the oxygen buzzing and the ventilator, or not the ventilator, but the oxygen buzzing, and so poor sensory stimulation. What can we do to make their life less painful, less monotonous, their time here on earth better? It may simply be to get them on a sitting up program, show the nurses how to cleanse their mouth, how to position their head, how to use wedges and bolsters to position them in their chair, teach them that they need to be up for 2 hours each shift, not from the end of third shift to the end of second shift, those kind of things. And to remember, and to get these referrals before it becomes critical. So one that comes to mind especially are the patients who need percussion and respiratory therapy. We don't want these patients once they're on the antibiotic and once they already have pneumonia. We want to get the referral when they have when they notice decreased breath sounds, or when they first notice rales, or when they are first starting to feel bad, when they are needing to have their nebulizer more frequently. That's when we want the referral, not once they've already had the chest x-ray and they already have pneumonia. We're trying to prevent getting them to that point. I mean, we want them when they have the pneumonia, but we're trying to prevent these problems from getting this bad. We want the patient before they get the pressure sore, before they have lost so much weight. We're trying to prevent these sentinel events, these bad issues. So communication with the nurses, with the aides, do in-services, and also the other point is to remember when we do the evaluation and we're writing down their history, we're not just filling out paperwork. We're just not writing down COPD, CHF, diabetes. Be thinking about how are these disease processes going to impact what I can do with my patient, how it's going to impact their progress, how it's going to impact how long it's going to take us to get to the end point, and making it clear to Medicare. That's why I need to see this patient 12 weeks. 12 weeks. It's not because she had a hip fracture. It's because she's got all this other stuff going on with her that brought her down below 0. And we've got to do all this exercise and range of motion and wrapping of her legs and blah, blah, blah to get her just to base level and then build her up from there. That's why, make it clear that that's why we need to see her for 72 minutes a day, 5 days a week for 12 weeks. And that's why we're writing all this information down about all her medical history and all of her medications, so that we're painting the picture accurately of what all's wrong with this patient, so that Medicare knows why we're needing to see this patient for so long or for so short a time. Or I'm rambling, but I hope you get the picture of the Medicare reviewer never sees our patient. We do. And I know that we're seeing, when we continue to see a patient, it's because we feel like there is something more we can do, where they're not better yet, or we'd be discharging them. So we need to convey that in writing to the Medicare reviewer. Okay, that's all for today, and I will see you in lesson 2.